Welcome, everybody. I don't really know how anybody actually follows Amanda. And this is obviously completely different, but I'll give it a shot here. So I'm going to try to figure this out. So I'm an internist, but I spend most of my time in our breast cancer and breast diagnostic clinics, and a lot of that with patients sorting out, do you have surgery first? Do you have medical treatment before surgery? And so it's kind of a routine for me to think through this process. I have no disclosures, and I thought it might be hopefully helpful to go through a little bit of the thinking process. Just for a basic definition, neoadjuvant therapy is basically preoperative cancer treatment. It doesn't refer to anything specific. In terms of breast cancer, though, it's specifically referring to either chemotherapy or endocrine, which is anti-estrogen therapy. We don't do radiation therapy before surgery in breast cancer. Primary surgical treatment, in other words, doing surgery is the first step in treatment of breast cancer. In the setting of a woman who wants breast conservation where she has limited volume disease, meaning that it's removable while maintaining the remainder of the breast without deformity, or mastectomy if you have a relatively high tumor volume, sorry for that repeat word there, when deformity is anticipated if you try to just remove the disease itself without the rest of the breast, if there's not a clear indication for preoperative therapy, or in the case of a woman who does qualify for neoadjuvant therapy but really prefers to have surgery first if there's not a contraindication to going that way. Mastectomy is also appropriate in the setting of future risk management, even if she has very limited disease, such as a very high-risk BRCA mutation, where their lifetime risk of another breast cancer is at least 50%. Or if the patient simply desires mastectomy after shared decision-making with her provider. This is a setting where medical therapy upfront and possibly as the only therapy is the most appropriate. This is metastatic disease stage 4, so lung, liver, and brain. So these women would not be candidates for surgical intervention, unfortunately. But it became obvious early on that in locally advanced disease, which means large volume disease, lymph node involvement, or involvement of the skin or the chest wall muscle, the pectoralis muscle, that these women early on were not really considered resectable. They had poor outcomes, high local recurrence, and poor survival if they did go to surgery first. So this was really the first group that did not have distant metastatic disease that we use neoadjuvant therapy for, and the clinical trials demonstrated significant tumor burden reduction, as well as improved disease-free and overall survival. This was also observed in women who had node-positive disease, that they had improved outcomes as well. These are a couple of examples. The woman on the top, she has inflammatory breast cancer on the left, and the reason this is a patient I took care of about 5 years ago, and I thought that this was actually a relevant picture because with her deeper pigmentation, it could be very easy for somebody who doesn't do this on a regular basis to miss her inflammatory disease, and I don't know if there's a pointer. This is the breast affected, and it's a little hard to see with the photographic projection, but she has erythema. She has peau d'orange change, which is that orange peel texture when the skin lymphatics are involved. And you can see that the breast is sort of diffusely swollen. So if you're paying attention, you won't miss this. The lady on the bottom is a woman I'm taking care of right now. She unfortunately has a pretty bad situation. We're in the process of working her up, but you can see that she has an ulcerating mass here. So this is clearly skin involvement. She also, it's fixed to the chest wall. The skin is diffusely involved here. And unfortunately, she has bilateral disease. This is actually her opposite breast cancer. And then for a third example, this is a patient I took care of recently as well, a 66-year-old lady who, it's a little hard to see on the photographic projection, but her breast cancer is about 9 centimeters in size. It involves all 4 quadrants of her breast and the nipple-areolar complex. And we just found out last week she has nodal involvement. These are a couple of MRs. The projections are different because of how MR sequencing works, but this is her breast in one sequence and this is the other. So she has really extensive disease. So these are examples of women who it's easy for me, relatively speaking, to tell them, you know, we need to do neoadjuvant therapy. Your outcomes will be better. So the positive outcomes in these sorts of patients led people to wonder about early breast cancer when they weren't so extensive, and could we make some gains there in overall survival and disease-free survival. And the early data, early meaning not terribly long ago actually, were suggesting that there really was no improvement statistically speaking, but there were benefits identified. Women were able to convert to breast conservation when mastectomy had been indicated otherwise. We were finding that node-positive patients were actually converting to node-negative, and now we're at a point where we can do less aggressive surgical intervention on the axilla. So some patients who might have had an axillary dissection, removing a large volume of lymph nodes from the axilla, the underarm, might actually be able to convert to a sentinel node biopsy, which is just removing a few, and if they're free of disease, we can spare the rest of the axilla, and that reduces the risk of lymphedema. And it also gives us predictive information from a biologic standpoint in terms of the response to therapy. These are a couple of women. This is one woman, the next slide is another, who have what we would consider high-risk disease. So this is a 35-year-old woman with a high-grade cancer, so rapidly dividing cells. And while she's hormone sensitive, hormone receptor positive, which is generally favorable, she's also HER2 positive, which is unfavorable, although we have targeted biologic therapy that definitely improves outcomes. And now we actually have what we call dual anti-HER2 therapy, so trastuzumab and pertuzumab, and outcomes are even better with dual anti-HER2 therapy. So this is high-risk disease. She's very high risk for distant relapse or stage 4 disease in the future. This is another lady that one of my partners is taking care of right now, also 35, and she has a small tumor. It's not even 2 centimeters. It's bumping up right against her pec, and you can't really tell from the MRI whether it's involving the muscle or not. But it's very close, and she's got 2 really high-risk prognostic factors here, which is that she's hormone insensitive, or ERPR negative, and she's HER2 positive. So this is very small disease in terms of how large the tumor is, but it's very aggressive disease. So these are women who are going to be, and they have been recommended neoadjuvant therapy, and I believe they're starting this week. So we are finding now, in more recent years, that certain biologic subtypes of breast cancer, we are seeing improved outcomes in disease-free survival and overall survival with neoadjuvant therapy. And what we're really looking at now is the pot of gold at the end of the rainbow, so to speak, is what we call a complete pathologic response, or a PathCR. And that's been predictive of improved outcomes for these patients who have what we call triple-negative breast cancer, or HER2-positive breast cancer. And with the HER2-positive breast cancer, it can be hormone-sensitive or hormone-insensitive. So this is really speaking towards individualizing therapy towards better outcomes. So just a very brief summary. This doesn't capture everything that is relevant in this. Clearly indicated in metastatic disease, meaning organ disease. These women may or may not ever get to primary surgery. Locally advanced disease, those first few women that I showed you would qualify in that category. And then high-risk disease, the last couple of women I showed you. Triple negative, meaning hormone insensitive, also HER2 negative, or HER2 positive disease, and also node positive disease. So I'm going to stop there. And this is sunny Rochester, Minnesota right about now. So.